femtosecond laser assisted cataract surgery, FLACS. That's the acronym we use in our practice. Three big objectives. We're trying to improve safety for our patients. We're trying to improve accuracy for our patients and improve predictability. We also call it robotic laser cataract surgery nowadays too. Now, I really look at cataract surgery. There is no such thing as a non-refractive procedure anymore. I think every patient comes in and they have some level of expectation. Now, whether that expectation be they want to be out of glasses for distance, for reading, or everything in between, there's always some expectation. And our margins for error are smaller and smaller. I mean, we're having such a smaller target to hit, and any advantage we can use to hit that target, that's something that we can take advantage of. And that's what femtosecond laser, the laser can help us do in cataract surgery. So it does make the procedure a little more automated, less variable, meaning better outcomes. Everybody wins. So before we get into the nitty gritty, Priya, as the surgeon, why don't you take us through the basic steps of cataract surgery? We can walk through that for our ODs.
Sure, I'd be happy to. Yeah, so here's kind of the steps in summarized in 10 steps. So step one, of course, we need an incision. So we need two incisions. We do make one for paracentesis and then one a main incision, what we're going to use for our phaco probe. I think if you're co-managing, it's good to know where those incisions are in case you ever need them to burp a wound or anything. So then we put in viscoelastic, make a rhexis, hydrodissection to mobilize the nucleus from the capsule. Then phaco, which there are various techniques depending on the surgeon, depending on the type of cataract. After the phaco, irrigation aspiration to remove the cortex. Then capsule polishing, if necessary. Then you actually put viscoelastic in before you put in the lens implant, and that's on phase 8. And then the last step is going to be removing all the viscoelastic before the end, which is when we put intracameral moxifloxacin and kind of pressurize the eye to a normal pressure.
So, I mean, it seems so simple. Obviously, it's not. I mean, when you really look at those steps, there's probably 5 spots that I think are highest potential for issues. The main incision, you want to have an incision that is watertight. You don't want an avenue for bacteria. Endophthalmitis is kind of a curse word in our practice. We don't like hearing that. So that incision is really important. The rhexis, making sure that that is done symmetrically and equal, because you want that lens to sit perfectly, especially with our more advanced lenses. Tip and tilt are very serious problems that can create higher order aberrations. Higher order aberrations that would negatively impact the quality of the vision. Third step, phacoemulsification. So the energy that's used to break up the lens, if we can lower the amount of energy, the eye is so fragile internally. The lower energy we use, theoretically, the better the healing process is going to be. And we kind of see that now with a lot of data points. Centration kind of goes with the rhexis. A good centered rhexis is going to lead to a good centered IOL, a good centered IOL. And then now we have the ability to treat low levels of corneal astigmatism. And we've always had this, but we've got a better ability now with laser to treat it maybe more accurately through relaxing incisions or AKs. So FLACS is not really that new. I mean, we've had it. The first one by Alcon was brought to market in 2010, but we've gotten better and better and better. And you know, the early generations are more like the iPhone 1. It was great. It was revolutionary. And now we're all the way to the iPhone 16, where we've just gotten better and the technology has improved so much. We've specifically in the last few years, I mean, we've improved our lens fragmentation. Our astigmatic correction has become a little bit more accurate. And now we're able to better tune in with our office diagnostics so we can more accurately do these procedures. So a couple benefits: we're increasing precision. We have the ability to center our capsulotomy every single time. The lens fragmentation lowers the phaco energy, more precise IOL arcuate, and improvement in visual refractive higher order aberrations. So what's the patient experience like? Low levels of astigmatism correction. You know, like I said before, there's really not such thing as a non-refractive. I mean, Priya, you know as well as I do. I mean, patients come in and they have some level of expectation. So me as an OD, if I'm fitting a contact lens and I've got somebody who's got 3/4 of a diopter of astigmatism, why would I not correct that? Of course I would correct that. I wouldn't leave that uncorrected, especially if it were an oblique axis or something like that. Well, in cataract surgery, I mean, with toric lenses, we usually reserve torics for a diopter and a quarter, diopter and a half. And anything less than that, we would just go spherical equivalent. So now we really have the ability to treat down to a certain level where it is visually beneficial. It improves the control of our premium lenses. These premium lenses also rely on optical principles of higher order aberrations. We're splitting light, we're stretching light. If we're doing that, we're trying to take advantage of certain principles. The lens has to be perfectly centered. Safety, like I mentioned, and then also high expectations. Expectations are super important in our premium world. Happiness is the difference between expectations and reality. So setting those expectations is really appropriate. And it really enhances the team approach. So Dr. John Vukic is my partner. Him and I work very closely together with these patients, trying to perfectly plan each procedure and execute each procedure and getting that patient to the post-op period so they can heal and visually rehabilitate.